Hello, dear student. Today we are continuing gastroenterology tract, and today's topic is chronic hepatitis. So let's start. Chronic hepatitis represents a series of liver disorders of varying causes and severity in which hepatic inflammation and necrosis continue for at least 6 months. Milder forms are non-progressive or only slowly progressive, while more severe forms may be associated with scarring and architectural reorganization, which when advanced lead ultimately to cirrhosis. Chronic hepatitis out classification. More than 6 months, similar features with acute hepatitis. Pathological classification. First, chronic persistent hepatitis, mononuclear infiltration. Second, lobular hepatitis, equal prolonged, slowly resolving hepatitis. Multifocal hepatocnecrosis, periportal fibrosis. And third, chronic active hepatitis, equal middle severe necroinflammation, monoinfiltration, piecemeal and bridging necrosis. And new classification is based on cause, grade histological assessment, stage by the degree of fibrosis. And what about cause? Chronic viral hepatitis caused by hepatitis B plus D, or hepatitis C. Autoimmune hepatitis based on serological distinctions, drug-associated chronic hepatitis, and a category of unknown cause of cryptogenic chronic hepatitis. And stage by the degree of fibrosis. The stage of chronic hepatitis, which reflects the level of progression of the disease, is based on the degree of hepatic fibrosis. When fibrosis is so extensive that fibrous septa surround parenchymal nodules and alter the normal architecture of the liver lobule, the histologic lesion is defined as cirrhosis. Staging is based on the degree of fibrosis as categorized on a numeral scale 0.6 HAI or 0.4 METAVIR. And on the left, you may see table with histological grading and staging of chronic hepatitis. And histological activity index and METAVIR index. And what about grade? Histological assessment. Grade, a histological assessment of necroinflammatory activity is based on examination of the liver biopsy. An assessment of important histological feature includes the degree of periportal necrosis and the disruption of the limiting plate of periportal hepatocytes by inflammatory cell. The degree of confluent necrosis that leaves or form bridges between vascular structures, between portal tract and portal tract, or even more important, bridges between portal tract and central vein, referred to as bridging necrosis. The degree of hepatocytes generation and focal necrosis within the lobule and the degree of portal inflammation. And on the left, you may see the histological activity index and known, minimal, mild, moderate, and severe. And characteristic for every this manifestation. Several scoring systems that take that histological feature into account have been devised, and the most popular are the histologic activity index, used commonly in the United States, and the METAVIR score used in Europe. Based on the presence and degree of this feature of histologic activity, chronic hepatitis can be rated as mild, moderate, and severe. And what is FibroScan? FibroScan is a useful test in almost any patient in whom a clinician wishes to stage liver fibrosis. The main drawback on FibroScan testing is that it cannot be performed in all patients. Technical limitation of the test preclude its use in the patients who have ascites, individuals who are morbidity obese, and all patients who have a large amount of chest wall fat. And next part of lecture, chronic hepatitis B. Chronic hepatitis B virus HBV infection has a worldwide prevalence of 257 to 191 million affected persons. Patients often remain asymptomatic for years but may unknowingly transmit the infection to others via perinatal, percutaneous, and sexual exposure or close person-to-person contact. An estimated 15–40 of HBV-infected patients may develop complications such as liver cirrhosis, liver failure, and hepatocellular carcinoma, which represent the common causes of HBV-related disease. Chronic viral hepatitis, including both chronic HBV and hepatitis C virus HCV infection, is responsible for approximately 1 million diseases worldwide and 20,000 in the US. What is a clinical presentation of chronic hepatitis B? Patient with chronic active hepatitis, especially during the replicative state, may complain of symptomology such as following. Symptoms similar to those of acute hepatitis: fatigue, anorexia, nausea, mild upper quadrant pain or discomfort. In progressive liver disease is present, the following symptomatology have appear. Hepatic decompensation, hepatic encephalopathy, somnolence, disturbances of sleep pattern, mental confusion, coma, ascites, gastrointestinal bleeding, and coagulopathy. The physical examination of patients with chronic hepatitis B virus infection can relieve stigmata of chronic liver disease, such as following: hepatomegaly, splenomegaly, muscle wasting, palmar erythema, spider angioma, and vasculitis. And chronic HBV infection is a dynamic process. The natural story of chronic HBV infection can be schematically divided into 5 phases, which are not necessarily sequential. And first, the immune tolerant phase. Second, the immune reactive HBe antigen positive phase. Third, the inactive HBV carrier state. Fourth, HBe antigen negative chronic hepatitis B. And last, fifth, HBs antigen negative phase. So you may see serological marker, and clinical significance. So, HBs antigen characterized acute or chronic infections. Anti-HBC immunoglobulin G characterized acute infection. HBe antigen characterized high infectivity. Anti-HBe characterized low infectivity. Anti-HBs characterized immunity. Anti-HBs and immunoglobulin G and HBs antigen characterized chronic infection, and anti-HBC immunoglobulin G and anti-HBs characterized resolved infection. So, diagnostic test. Chronic active HBV disease is characterized into HBe antigen positive and HBe antigen negative disease. Subtype wild type of HBe antigen positive disease. Patients have mild to moderate elevation of the aminotransferases. The ALT levels are usually higher than IST levels. Extremely high level of ALT can be observed during exacerbation or reactivation of the disease, and they can be accompanied by impaired synthetic function of the liver. And subtype chronic HBe antigen negative disease. Note that although the HB antigen result is negative in this stage, HB antigen negativity can be associated with greater HBV DNA replication and more rapid disease progression in patients who carry mutation in either the press core of the basic core promoter region of the HBV genome. So, alanine aminotransferase, ALT, it is enzyme found mostly in the cells of the liver and kidney. Normally, ALT level in blood are low, but when the liver is damaged, ALT is released into the blood and level increases. Aspartate aminotransferase, AST, is an enzyme found in cells throughout the body, but mostly in the heart and liver, and to lesser extent in the kidney and muscles. In healthy individuals, level of AST in blood are low. When liver and muscle cells are injured, they release AST into blood. AST, however, is not specific for the liver and may be increased in conditions affecting other parts of the body. Gamma glutamyl transferase is the enzyme that is found in many organs throughout the body, with the highest concentration found in the liver. Gamma glutamyl transferase, GGT, is usually the first liver enzyme to rise in the blood when any of the bile ducts that carry bile from the liver to the intestines become obstructed. GGT levels are sometimes increased with consumption of even small amount of alcohol and may be used in evaluating someone for acute or chronic alcohol abuse. The GGT test is not very specific for liver and is not useful, is differentiated between various causes of liver damage. Alkaline phosphatase is an enzyme found in liver tissues throughout the body. The ALP in blood sample of healthy adults comes mainly from the liver, with most of the rest coming from bones. Elevated levels of ALP in the blood are most commonly caused by liver disease, bile duct obstruction, gallbladder disease, or bone disorders. In the liver, ALP is found on the edges of the cells that join to form bile ducts, tiny tubes that drain bile from the liver to the bowels, where it is needed to help digest fat in the diet. ALP in bone is produced by special cells called osteoblasts that are involved in the formation of bone. Each of the various tissue types produce a distinct form of ALP called isoenzymes. Not all patients with chronic HBV infection have persistent elevated aminotransferases. Patients in the immune tolerance phase and active carrier have persistently normal ALT level, while a proportion of patients with appropriate longitudinal long-term follow-up is crucial. Anemia due to shortened red blood cell survival period is an infrequent finding, although hemolysis may be noted. Thrombocytopenia is a rare finding. Patients with severe hepatitis experience a prolongation of the international normalized ratio, INR. The assessment of the severity of the liver disease should include biochemical markers, including aspartate aminotransferase and alanine aminotransferase, gamma-glutamyl transpeptidase, alkaline phosphatase, bilirubin, and serum albumin and globulins, blood counts, and prothrombin time, and hepatic ultrasound. Usually, ILT level are higher than those of AST. However, when the disease progresses of cirrhosis, the ratio may be resolved. Liver biopsy and histological feature. Liver biopsy, percutaneous or laparoscopic, is the standard means on assessing the severity of disease in patients with features of chronic active liver disease. Although liver biopsy is not indicated for patients with acute hepatitis B disease, the findings in the acute phase are predominantly lobular with generative and regenerative hepatocellular changes, as well as accompanying inflammation. Necrosis may be predominantly centrilobular. The hallmark of chronic hepatitis B infection is lymphoid inflammation, mostly involving the portal tract. However, occasional concealment bodies are seen in the label. Hepatitis are distended with viral particles may occur unusual gross glass appearance of the hematoxylin and eosin stain. Ground glass cells are seen in approximately 50–75% of liver affected by chronic HBV infection. And on the right, you may see histology, and A. The pathological diagnosis was with mild hepatitis. B. Mild portal and perivenular fibrosis. C. The specimen inhibited central necrosis. And D. The specimen showed infiltration of inflammatory cells consisting of lymphocytes and plasma cells with mild interface hepatitis in the portal zone. And treatment for chronic hepatitis B. 3 criteria for treatment prescription are used: serum HBV DNA level, serum ALT level, and histological grade and stage. Patient with moderate to severe active necroinflammation and or fibrosis in the liver biopsy with HBV DNA above 2000 international units on milliliter and or ALT above the upper limit of normal. Age on comorbidities also affect the decision to treat and with which agents. If cirrhosis present, treatment should be given independent of ALT or HBV DNA levels. Patients with decompensated cirrhosis can also be treated with oral antiviral agents, but liver transplantation may be required. Immunotolerant patients, usually young with persistently normal ALT and high HBV DNA levels without evidence of liver disease, and without a family history of cirrhosis or hepatocellular cancer, do not need therapy but must receive follow-up. The aim of treatment is a seroconversion of HBe antigen that present to anti-HBe and the reduction of HBV DNA to 400 international unit on liter or less measured by sensitive PCR techniques. In addition, normalization of serum ALT, histological improvement in inflammation and fibrosis, and loss of HBV, HBs antigen reflect a good response. If HB antigen disappears, remission is usually sustained by many years. Patients usually remain HBs antigen positive, but there is small but incremental loss of HBs antigen annum. And antiviral agents for hepatitis B. Methylated alpha-2A interferon give response rate of 25-45% after 48 weeks of treatment. Patients with higher serum aminotransferase value who are younger with viral loads less than 107 IU on milliliter respond best. Patients with concomitant immunodeficiency virus respond poorly, and those with cirrhosis should not receive interferon. Side effects of treatment are many, with the acute flu-like illness occurring in 6-8 hours after the first injection. This usually disappeared after subsequent infection, but malaise, headaches, and myalgia are common. Depression, reversible hair loss, and bone marrow depression and infection may also occur. The placement count should be monitored. In older patients, HBe antigen usually disappears. And oral therapy and variant of antiviral drugs. Entecavir, tenofovir, lamivudine. And possible outcomes of HBV infection. Yeah, you may see acute hepatitis B infection may transfer chronic hepatitis B after chronic hepatitis, after cirrhosis, and cirrhosis may transfer to hepatocellular carcinoma and transfer this of liver transplant and transfer liver failure and also liver transplant and this. Chronic hepatitis C. Chronic hepatitis C is an infection caused by hepatitis C virus that attacks the liver of the and that leads to inflammation. The World Health Organization estimates that above 71 million people globally have chronic hepatitis C, with approximately 399,000 dying from the infection, primarily due to cirrhosis and hepatocellular carcinoma. World Health Organization estimated that in 2016, approximately 389,000 people died from hepatitis C. Antiviral medicines can cure more than 95% of persons with hepatitis C infection, thereby reducing the risk of death from cirrhosis and liver cancer. But access to diagnosis and treatment is low. And epidemiology. 7 genotypes identified, many subtypes and quanti-species, is the US variant GT1A more than 1B, GT2-3, and GT4. Genotype direct therapy and predict response to therapy. And outcomes. HBV established a chronic state in most infected patients, risk factor for progression, old age or infection, alcohol use, co-infection with immunodeficiency virus, or HBV, chronic hepatitis B. And progression from normal liver to carcinoma. And time 25 or 30 years for this progression. Pathophysiology. Chronic HCV infection induced immune dysfunction such as impaired T cell functions and inefficient antibody response. Metabolic disorders such as hepatic steatosis, iron accumulation, and insulin resistance often associated with type 2 diabetes. More importantly, HCV is one of the major etiologies of chronic hepatitis and progressive liver fibrosis that lead to the development of lethal complications, cirrhosis, and hepatocellular carcinoma. HCV infection can induce chronic hepatic inflammation with varying activity, which causes progressive liver fibrogenesis and leads to the development of cirrhosis. First, metabolic reprogramming including disturbances of lipid metabolism and mitochondrial dysfunction. Several studies highlight a role of the HCV core protein in steatosis and hepatocellular carcinoma nodal development as well as in insulin resistant, which is accompanied with intrahepatic lipid accumulation. Hepatitis C core protein was also shown to contribute to mitochondrial damage by impairing mitophagy. The resulting oxidative stress is regarded as a key trigger of carcinoma initiation and development. Hepatitis C proteins were reported to have both pro-apoptotic and anti-apoptotic properties. Viral proteins impact on epithelial mesenchymal transition pathway, which promote fibrogenesis, tumor development, and metastasis. And clinical examination. Most patients with hepatic C virus infection do not abnormal physical examination findings until the development portal hypertension or decompensated liver disease. One exception in patients with extrahepatic manifestation or HCV infection, such as porphyria cutaneous tartar or necrositine vasculitis. Since in patients with decompensated liver disease include the following: hand since palmar erythema, dupuytren contracture, osteoarthritis, leukocyenia, clubbing. Head since icteric sclera, temporal muscle wasting, enlarged parotid, cyanosis. Fetor hepaticus, gynecomastia, small testes, abdominal sins, paraumbilical hernia, ascites, caput medusa, hepatosplenomegaly, abdominal bruit, ankle edema, scant body hair, skin sins, spider nerve, petechia, excursions due to prepitus. All the common extrahepatic manifestation include the following: cryoglobulinemia, membranoproliferative glomerulonephritis, idiopathic thrombocytic purpura, and lichen planus. And on the right, you may see picture with lichen planus. And the most recent recommendation of the American Association for the Study of Liver Disease and Infectious Disease Society of America. And these guidelines recommend the following for initial HCV testing and follow-up. Initial HCV testing, HCV antibody test, if the result is positive, confirm recurrent infection with a sensitive HCV RNA test. Negative HCV antibody test but clinical suspicion of the liver. Test for the HCV RNA or follow-up testing for HCV antibody if HCV exposure occurred within the past 6 months. Consider testing for HCV RNA in immunocompromised individuals. Reinfection after previous spontaneous or treatment-related viral clearance. Obtain shown in HCV RNA testing before initiation of antiviral therapy. Obtain quantitative HCV RNA testing to document baseline viral load. Selection of the most appropriate antiviral regimen. Use HCV genotype testing for guidelines. Positive HCV antibody test with negative HCV RNA by polymerase chain reaction. Inform patients they do not have evidence of current HCV infection. And World Health Organization recommend nucleic acid testing for qualitative and quantitative HCV RNA detection, as well as for tests of cure of 12 or 24 weeks following antiviral completion. In areas with limited resources, the World Health Organization suggests using the aminotransferase or platelets ratio index of the fibrosis score for evaluating hepatic fibrosis rather than other non-invasive tests that require more resources as follows. And you may see this formula, this index, APRI index, and fibrosis 4. Please read this information with details. Other baseline studies include the following: complete blood cells count with differential, international normalized ratio, liver function test including level of ALT and AST, alkaline phosphatase, albumin, total and direct bilirubin, calculated glomerular filtration rate, thyroid function studies, screening test for co-infection with human immunodeficiency virus or chronic hepatitis B, screening for alcohol abuse, drug abuse, and or depression. Hepatitis B virus testing with hepatitis B surface antigen, as well as hepatitis B surface antibody and antibody against hepatitis B co-antigen, serum pregnancy testing in the women of childbearing age before initiation a treatment regimen that includes ribavirin or what includes direct acting antiviral agent without ribavirin. The HBC demonstrated thrombocytopenia in approximately 10% of patients. Low thyroxine levels are found in approximately 10% of patients as well. Stress testing may be necessary in appropriate patients, and ophthalmological examination may also be necessary. And HCV genotyping. Hepatitis C virus genotyping is helpful for predicting the likelihood of response and duration of treatment. Genotyping can be performed by direct sequence analysis, reverse hybridization to genotype-specific oligonucleotide probes, or restriction fragment length polymorphism. In addition to HCV genotypes, a growing body of research indicates the patient genetics play a role in the response to treatment. And you may see 6 different subtypes of HCV genotypes. Histologic findings. Liver biopsy is not considered mandatory before the initiation of treatment for hepatitis C, but it may be helpful for assessing the activity and severity of hepatitis C virus-related liver disease. However, some experts recommend biopsy only in the following situation: the diagnosis is uncertain, other co-infection or disease may be present, the patient being considered for treatment has normal liver enzyme level and no extrahepatic manifestation, and patient is immunocompromised. Lymphocytic infiltration, moderate degrees of inflammation and necrosis, and portal of bridged fibrosing are noted in hepatitis C. Regenerative nodules are seen in patients with cirrhosis. Some patients also may have findings indicative of hepatocellular carcinoma. And fibroscan is a diagnosis of hepatitis C virus infection. The most important aspect in the evaluation of patients with hepatitis C infection is determine whether or not he or she has cirrhosis. This is the most important part of staging because very specific guidelines define how one should proceed with patients with cirrhosis irrespective to screen them every 2-3 years for esophageal varices and portal hypertension and putting them into a program with cross-sectional imaging, ultrasound, computed tomography, or magnetic resonance imaging every 6-12 months for monitor risk of the cancer. And the most widely used tests for liver fibrosis in the United States are the FibroSure and HepaScore. Both tests are very good in terms of their sensitivity and specificity is diagnosing cirrhosis, but similar to biopsy, they are not as accurate for extract identification of intermediate stages of disease. And antivirus therapy for chronic hepatitis C should be determined on a case-by-case basis. However, treatment is widely recommended for patients with elevated serum alanine aminotransferase level who meet the following criteria: age older than 18 years, positive HCV antibody and serum HCV RNA test result, compensative liver disease, acceptable hematological and biochemical indices, willingness to be treated and to adhere to treatment requirements. No contraindications for treatment. A further criteria is liver biopsy finding consistent with the diagnosis of chronic hepatitis. While lower suppression reduces the risk of hepatitis C liver morbidity and mortality. And antiviral agents of hepatitis C. Current treatment in combination therapy with pegylated interferon with a polyethyl ethylene glycol tail and ribavirin for genotype 1 only. Combination PEG and R is combined with other of two NS3 protease inhibitors, tenofovir and boceprevir. Other drugs, NS5B protease inhibitor, cyclosporine inhibitor, new types of interferon and ribavirin analogs are all being developed, which will change few treatment algorithm. Treatment duration with PG R alone is 12 months for genotypes 4 and 6 and 6 months for genotypes 2 and 3. And as short as 6 months for some genotypes 1 patient received triple therapy. And you may see combination therapy with those drugs. With dose and with right dose and duration between these drugs. And co-infection, hepatitis C and human immunodeficiency virus. Patients co-infected with human immunodeficiency virus and hepatitis C virus are at risk for accelerated liver fibrosis and should usually be offered antiviral treatment. HIV, HCV co-infected persons should be treated and retreated the same of those without HIV infection once any interactions with antiretroviral agents have been identified and managed. Daily daclotazevir plus sulfosburin with or without ribavirin is a recommended regimen when antiretroviral regimen changes can be made to accommodate alternative HCV direct-acting antiviral medication. However, the combination of ledipasvir, sulfobuvir for 8 weeks is not recommended regardless of the patient's baseline HCV RNA level. And some words about chronic hepatitis D. Hepatitis D virus is a virus that requires hepatitis B virus for its replication. Hepatitis D virus affects globally nearly 5% of people who have a chronic infection with hepatitis B virus. Several rare geographic national Hotspots of high prevalence of HCV infection exist, including Mongolia, the Republic of Moldova, and countries in Western and Middle Africa. Populations that are more likely to have HBV and HCV co-infection include people who inject drugs, indigenous population, and recipients of hemodialysis. HCV-HBV co-infections is considered the most severe form of chronic viral hepatitis due to more rapid progression towards liver-related disease and hepatocellular carcinoma. This is related infrequent chronic hepatitis, but spontaneous resolution is rare. Between 60% and 70% will develop cirrhosis and more rapidly than with HBV infection. Currently, treatment success rate is generally low. Hepatitis D infection can be prevented by hepatitis B immunization. HCV infection is diagnosed high levels of immunoglobulin G and immunoglobulin M anti-HCV and confirmed by detection of HCV RNA in serum. Current guidelines generally recommend pegylated interferon alpha for at least 48 weeks, irrespective of on-treatment response patterns. And some words about autoimmune hepatitis and 3 pearls for this variant of hepatitis. Approximately 20% of patients with autoimmune hepatitis will be antibody negative. Always consider drugs-induced autoimmune hepatitis like liver injury in the DDX of autoimmune hepatitis. If discontinuation of drug doesn't improve condition, consider this variant of hepatitis, and presence of at least one other autoimmune disease is fairly common among patients with autoimmune hepatitis, and diagnosis screen for celiac and thyroid disease. So, thank you very much for your attention. If you have questions, please leave your comment under the lecture. And see you again, and good luck, dear student.